Good afternoon, ladies and gentlemen, dear colleagues. It is my great pleasure to introduce all of you to this special luncheon symposiums about the cardiac transplant or what else we can offer to strengthen the heart with medical code Q10 might be an alternative. Our guest speaker for today comes from Melbourne, Australia. He is Professor Franklin Rosenfeld from Cardiac Surgical Research Unit, Alfred Hospital, Melbourne, Australia. For the people who came into our session this morning, I already introduced Professor Rosenfeld one time, and I will introduce him to all of you once again. Professor Frank Rosenfeld is a renowned cardiac surgeon affiliated with the Alfred Hospital in Melbourne, Australia, one of the world's leading healthcare centers and specialists in cardiovascular medicine, heart and lung transplant, trauma care, oncology, and respiratory medicine. Professor Rosenfeld has conducted groundbreaking research in the field of cellular metabolism and, more recently, the supportive role that complementary medicine can play in cardiac surgery and cardiology. His dedicated work has focused on the role of coenzyme Q10, fish oils, and antioxidants together with mind-body medicine and meditation, stress reduction and physical exercise in the management of heart disease, protection of the heart against damage during cardiac surgery, and transplantation has been a lifelong interest, and one of which Professor Rosenfeld has established an international reputation. So let us all welcome Professor Rosenfeld.
Well, thank you very much, Mr. Chairman. It's a great privilege to speak to you again, twice in one day, but I'll be talking about something a bit different. And it's a great pleasure to have Dr. Angcharit in the audience, who's a very good friend of mine. And we all noticed that the title of this is cardiac transplantation or something else. Well, Dr. Angcharit did the first heart transplant in Thailand 29 years ago, I think, and the patient is still alive. So heart transplantation is a wonderful therapy, and I'm working in that field myself and have been for the last few years in preserving donor hearts. So heart transplantation is very important. But heart transplantation is very expensive, and it's, as you know, in Thailand and elsewhere in the world, it's very hard to get donors. So what we really need to do is try to cut off the need and reduce the need for heart transplantation by more effective methods of treatment of heart failure. So today I'd like to talk partly about what I spoke about this morning, the QSYMBIO trial, but then go on to talk more about coenzyme Q10 and its other uses. So I'll be talking about coenzyme Q10, what it is, its use in heart failure, hypertension, ageing, cardiac surgery, and a mention of its use in sport. So what is coenzyme Q10? Well, coenzyme Q10 is also known as ubiquinone, and this is the molecule here. That's the quinone ring with the 10 isoprenoid units on the end of it. That's why it's called Q10. It's a cellular energizer which produces energy in the mitochondria, an antioxidant, and regulates genes, some of which, concerned with metabolism, are upregulated. So how does coenzyme Q10 work in energy production? Well, here we can see the inner mitochondrial membrane with the respiratory chain, with the 4 main complexes that transport electrons down through the electron transport chain and eventually create a proton gradient which eventually produces ATP. And you can see that in the centre of this, it's like a conveyor belt that brings electrons down the chain. There is coenzyme Q10, which is very important as part of producing energy. And when it's deficient, energy production can be interfered with. So what about coenzyme Q10 in heart failure? Now, you all realise that most of the heart failure therapy simply blocks nature's compensatory mechanisms. So when you think about it, there's low renal perfusion, results in fluid retention, activation of the renin-angiotensin system, aldosterone secretion. So what do cardiologists and the rest of us do? We give them blockers to block the fluid retention, block the angiotensin system and the aldosterone system. So just blocking nature's compensation. Low cardiac output, that causes raised filling pressure and fluid retention again. So we use fluid restriction and diuretic therapy. Low cardiac output also activates the sympathetic nervous system. We use beta blockers to prevent that. And there's vasoconstriction, so vasodilators. So these are all blockers, but one of the main problems and the cause of heart failure is a lack of energy in the cell. And that is where therapies that improve energy production have got a future, I believe. So is the failing heart energy starved? This is a study from Joanne Ingwall in the US. And this is an MRI of a normal heart and a failing heart. And this is a magnetic resonance spectroscopy looking at the high energy phosphates in the heart itself. And we can see here that in the normal heart there's a big peak of creatine phosphate and several peaks of ATP, but in the failing heart these peaks are lower. So creatine phosphate is reduced by 40% and ATP is reduced by 15%. So there's less energy in the failing heart. Also, in dilated cardiomyopathy, a low cardiac energy level is a very good predictor of mortality as much as NYHA. So the lower the energy, the higher the mortality. And here we can see this is the mortality in heart failure. And we've got two groups. There's the lower line here, which has got more energy, creatine phosphate ATP ratio greater, and the low energy here has got the higher mortality. So it's as good as NYHA classification to predict which patient is going to die. If they have a low energy level, their mortality is higher. Also, in the respiratory chain, some work from our laboratory a few years ago focused on the different complexes. So complex 1 is the first step in the electron transport chain. And we took pieces of heart. As we're transplant surgeons, we could get bits of the donor heart, which was a normal heart, and bits of the recipient heart, which is a failing heart, and look at the level of the complex 1. We can see that in the heart failure, they had less complex 1, so they were less able to make energy through complex 1. Similarly with complex 4, which is also known as cytochrome oxidase, this was also reduced. We can see here, this is the complex 4 activity in the donors, and the heart failure was lower. So less activity of complex 4. So conclusion, the failing heart is an energy-starved heart. It doesn't have enough fuel in the tank, you might say, to beat properly. So how can the energy production in the heart be improved? Well, this is some data from Carl Folker's where he looked at biopsies from endocardial biopsies from patients in the transplant laboratory, and we can see this is NYHA class 3 and 4, and the level of coenzyme Q10 is 0.28, whereas in class 1 and class 2 had a higher level. So again, a bit like the complexes, there's less coenzyme Q10 in the failing heart. So the respiratory chain for energy production, so if we could increase the coenzyme Q10, surely that would be beneficial. Now, a few years ago, we did a study, again, using our ability with cardiac surgery to get pieces of human heart tissue. When we cannulate the heart, we remove a bit of the atrial appendage, and we could take it to the laboratory and extract the mitochondria. And we were able to then look at the efficiency of mitochondrial ATP production in human myocardium was increased by coenzyme Q10. So what we did as preoperative preparation, we gave the patient 300 milligrams a day of coenzyme Q10 for 2 weeks, and then we looked at their mitochondria in laboratory, and we found that the efficiency of energy production, that's the ADP-O ratio, that's the amount of ADP changed to ATP, was higher in the CoQ10 treated patients than placebo treated patients. That is to say, for each mole of oxygen that was used, more energy was produced, so there's more bang for your buck. So in conclusion, coenzyme Q10 can improve mitochondrial energy production. Now, what's another thing that goes wrong in heart failure apart from energy starvation? Oxidative stress. Now, there's been an actual book produced about oxidative stress in heart failure called Oxidative Stress and Cardiac Failure, a multi-author text with a lot of very interesting information about oxidative stress in heart failure. And this is one of the parts from that monograph. Increased urinary isoprostanes correlate with severity of heart failure. Now, when you have oxidative stress, that damages the lipids and you get isoprostanes secreted in the urine. So the higher the isoprostanes, the more oxidative stress. So we can see here controls, class 1, class 3, class 4. So as the heart failure gets worse, there is more oxidative stress. So how can oxidative stress by free radicals be prevented? Well, by antioxidants. And many antioxidants have been tried for heart failure, as you know, over the years, which were largely negative. Vitamin E didn't seem to work, but coenzyme Q10 does seem to work, and also carvedilol, which many of you will prescribe your patients, is not only a beta blocker, but it's also a potent antioxidant. So let's move on to the coenzyme Q10 study. This was published in the Journal of the American College of Cardiology, heart failure section, and I was one of the co-authors, and it came from our unit and 8 centres around the world, a multi-centre trial, and it was really the first randomised controlled trial of coenzyme Q10 adequately powered to show a mortality benefit with adequate dosage and long enough follow-up to assess the mortality. Whereas a lot of the previous trials, which were being criticised by the sceptics, had small numbers and a short follow-up time. So this overcame all those problems. It's called QSYMBIO, improvement of symptoms, biomarkers, BNP, and long-term outcomes. So the methods, there are 420 patients with moderate to severe heart failure, class 3 or 4, randomly assigned a 2-year prospective trial to either CoQ10, 100 milligrams 3 times daily, or placebo, in addition to standard heart failure therapy. So they were all having maximal therapy already. 16 weeks, the primary endpoints were NYHA classification, 6-minute walk test, and BNP. And at 2 years, the primary endpoint was major adverse cardiovascular events, including mortality, rehospitalisation for heart failure, transplants, etc. So the baseline characteristics, they were very comparable between the two groups. This is the CoQ10 group and the placebo. The age was the same and all the other parameters were not different. They were both mainly class 3, 88% and 87%. And left ventricular ejection fraction, 31% in both groups, and BNP was raised in both groups. What about the medications? Well, these were, the common medications were all present in both groups, 90% ACE inhibitors, 72% beta blockers, etc. So there was no difference between both groups were having adequate heart failure therapy. So coenzyme Q10 was being given in addition to standard therapy in all cases. So what are the results? So I'll firstly summarise them here and then go through them in more detail in a moment. So the short term, 16 weeks, all-cause mortality was lower in the CoQ10 group with a hazard ratio of 0.18, which was highly significant, but there were no changes in the other endpoints, only the mortality was different. The long-term 2-year, the primary endpoint of major adverse cardiovascular events was reached in 15% of the patients in the CoQ10 group and 26% in the placebo group, which was significantly higher. Secondary endpoints were lower in the CoQ10 group. Mortality was lower, cardiovascular mortality 9 versus 16, all-cause mortality 10 versus 18, hospitalisation for heart failure 8 versus 14, NYHA improvement was better, and serum BNP was reduced but was not significantly different between the two. So let's look at some of the results in detail. This slide shows the freedom from cardiovascular death. So the patients with the CoQ10 is in the dotted line and the placebo in the continuous line. We can see that the coenzyme Q10 patients, more of them were free of cardiovascular death than the placebo-treated patients. So in numbers, there were 9% were free of cardiovascular death and 16% the placebo group, which was highly significant. So more mortality from heart-related causes. Freedom of death from any cause, a similar pattern, with the coenzyme Q10 group being significantly higher, freedom from death, and than the placebo group, and that was highly significant. And in numerical representation, 10% deaths in the CoQ10 group and 18% in the placebo group, a 42% relative reduction, which was significant. Freedom from major adverse cardiovascular events, so I said that was transplantation, death, readmission for heart failure. Again, a similar pattern with the coenzyme Q10 group being better than the placebo group, which was highly significant. And numerically, 15% of the primary endpoint at 2 years, 15% whereas 26% in the placebo group. So more in the placebo group had major adverse cardiac events. And freedom from unplanned hospitalisation for heart failure was better in the CoQ10 group than the placebo group. It was not quite significant at the 0.05 level. What about side effects? The number of side effects in the CoQ10 group, 13%, was no different to the placebo group. So significantly no side effects from the treatment. Now, let's look at the subgroup analysis to look at were there any subgroups of patients that benefited more than others for the major adverse cardiac events. We can see that age, that patients over 67 were more likely to benefit than those that were younger. Males were more benefit than females. New York Heart Association Class 3, they were more likely to benefit than Class 4. Perhaps the Class 4 were too advanced for therapy. Dilated cardiomyopathy was more affected than non-dilated, including ischemic. Raised BNP, if you had a raised BNP, there was more of an effect of coenzyme Q10 than those with a normal BNP, which you might expect. And ejection fraction, over 30%, were benefited more than those with a lower 30%. In other words, perhaps the most advanced ones were unable to benefit. And finally, ACE inhibitors. Patients on ACE inhibitors were benefited more than those not. So ACE inhibitors certainly didn't cancel out the effect of coenzyme Q10. So, of course, this sort of therapy meets with scepticism, especially in Australia. We need more work on this. It looks good, but we need lots more trials. But should we wait for more trials? Well, CoQ10 is a non-patentable substance, and so the QSM Bio trial had a low budget, and this is why the trial was not completed according to the original enrolment plan, 440 rather than 550. So there really aren't going to be any more large randomised trials of coenzyme Q10 in the foreseeable future. So low-risk treatments with no side effects, such as CoQ10, require lower levels of evidence than those with high or more side effects. So maybe the JAC, the American College of Cardiology guidelines usually require 2 large randomised trials, but these would be for treatments which do have a downside to them. In this case, there's no real downside, so we'd submit that it's sufficient to at least consider using coenzyme Q10. So conclusion, the results demonstrate that treatment of coenzyme Q10 in addition to standard therapy for patients with moderate severe heart failure is safe, well tolerated and associated with a reduction in symptoms and mortality and major cardiac events. So now change gear and now talk about coenzyme Q10 hypertension.
Let's pause here just a little.
Yes.
Or maybe we focus more on the heart failure, which is the major point of discussion for today. Anybody have any question for Professor Rosenfeld about his presentation?
So feel free to interrupt and ask some questions.
Because usually when we have this kind of trial, we used to ask many questions. One thing that I have in mind is, do we have enough patients to get to this conclusion correctly about the way that it can reduce the mortality in heart failure, maybe something like 40%. Do we have enough patients in the trial that can solve this problem, this question? The
yes,
number
well,
of the patients.
When you do a sample size calculation, you work out the minimum number you need to get an effect. And if we had not got an effect, as we had 440 instead of 550, you might say, well, if you'd had more patients, you would get an effect. But we already had an effect with a smaller number. So the effect size was actually greater than was expected in the sample size calculation. So this was really enough to be significant in all the outcomes. So I think there were enough patients. I know we're familiar with the big pharma trials where you might have 1,000 patients and you can find a small difference, but I think the fact that we showed a difference with only 440 patients means that it was a real difference.
And one of the most asked questions is about, do you treat the control arm properly? Such as your data said, you use aldosterone antagonist for about maybe 30% of the case, which may be not enough for this kind of severity of heart failure. We use more aldosterone antagonists. I agree with you that we use quite a lot of ACE inhibitor already, nearly 90%. However, the number of the patients who exposed to aldosterone antagonists in both arms may be too small. What do you think about that? It's only 30% or something.
Yeah, we can look at that. So this is the, so you're saying that the ACE inhibitors, 90% had that and 70% had beta blockers. So I think they...
For 70% of beta blocker, I agree with you that some of them may not tolerate beta blocker as good as the other. But for the aldosterone antagonist, over there, okay, so only 34%, maybe too small. Come down.
This one here, aldosterone take.
Because
okay.
this is usually the standard of the treatment at this time. So we like to put them, all of them, into the aldosterone antagonist more than only 1/3.
Well, I think the thing was that this trial started quite a few years ago, so the aldosterone antagonists weren't quite so popular. So I think they've gradually come into. So I think you could say, well, perhaps we should have had more on these. That's a good point. But the thing is that as time goes on, more and more treatments for heart failure come along, and I think we had to do what we had to do at the time, and whether that would have made a difference is impossible to say. I think we can say they were on the maximum treatment that was available at the time.
For the early phase of the research in coenzyme Q10, I saw many different doses and form of coenzyme Q10. So the question is, what is the best coenzyme Q10 dose that we should use in our patient with heart failure?
Yeah. Well, coenzyme Q10 is an interesting substance. It's not very well absorbed, actually, and a lot of it is not absorbed in the gut. So it's important to have the right sort of formulation. And ideally, you measure the coenzyme Q10 level in the blood and then give the therapy and then measure the level afterwards, and it should be about double. And it was actually, I haven't shown that data, but it was increased. So it does make a difference. And if you buy coenzyme Q10 on the internet, you don't really know what you're getting. So it's good to have a form of coenzyme Q10 that is properly certified and not just something that's come out of nowhere, you know. And I won't quote any particular brand, but I know in Australia there are several good brands, and I think the same elsewhere, where the bioavailability has been established. And I understand that in certain countries, coenzyme Q10 is registered as a drug. So in order for it to be registered, it has to go through a very thorough bioavailability data. And I think that would be important before putting your patients onto coenzyme Q10 to make sure that it's the right thought. In fact, with the when this paper came out in the American College of Cardiology, there was an editorial on it. And one of the things the editor said was, well, you know, there are all these sort of things you can get off the shelf, and we don't know whether they've got coenzyme Q10 enough in it or not. And that's quite true. In the United States, there's no real control of complementary medicines at all. So anyone can make up a pill and put it on the shelf, whereas in Australia you have to get an AUSTEL number, which means it's been made under good manufacturing practice and that it's got a certain amount of minimal, not efficacy, but properly manufactured. So I think probably the same in Thailand. Do you have a process like that to certify things are good or not good? No. Well, there you are. So I think it's up to each physician then to look at whatever they're going to give the patient and just look and see, is this a reliable product? Because it costs about in Australia about $1 a day to take coenzyme Q10, and it's not on the free list. So the patient's going to pay for it, or maybe they can get it. You can put on a prescription. So before you use it, then you have to make sure it's a reputable product.
Just one more question before we move on. Talking about the decrease in cardiovascular events, which is cardiovascular death and cardiovascular hospital admission for heart failure, right? And you also mentioned about the need for transplantation. How many cases that need to do the transplantation in the placebo and in the Q10 arms?
Yeah, I think there's only about 2 or 3 in each group. It was
so not much,
relatively rare. Yeah, very few.
Okay. So I think that we better move on to another part of the coenzyme Q10, which may be more difficult. We have less data than in heart failure, right? So you can proceed.
Yeah, okay. Any other questions about that?
Thank you. Great study. Regarding the coenzyme Q10 doses, like what Dr. Abhishad mentioned, would you mind comment more on why it has to be TID? Just because of the absorption? Like, can we take 300, like 3 pills at the same time?
Yeah, it's better to take it at least twice a day. If you take it once a day, it isn't absorbed so well. So we said 3 times a day, but I think we know that you can take it twice a day. It's quite hard to get patients to take a tablet in the middle of the day. So I think preferably you could take in 2 divided doses.
And you from your opinion, you think that the way that this trial have a high magnitude of effect, is it because of the trial use higher dose of CoQ10 than other trial, and is this the right dose? Can we go even higher than this?
Well, I think it was a formulation that was well absorbed. I think that was the thing. Some of the early trials used a powdered form of coenzyme Q10 which wasn't well absorbed, and there've been a whole, if you go onto the internet and look up coenzyme Q10, you'll see masses of places you can get it from. So I think the one that was used here was well absorbed, and that was gave a good blood level. We found that. So I think that's probably the reason that if you take more, probably you wouldn't get much higher blood levels unless there are some people who don't seem to absorb coenzyme Q10 very well. You probably know yourself that if you've got advanced heart failure, you get edema of the gut, and most medications aren't well absorbed. So particularly patients in class 4 heart failure, they've got gross edema and they don't absorb things. So in some of those maybe you could use a higher dosage, but the best thing if possible is to measure a blood level, which can be measured, and then if you know it's 2 or 3 times the baseline, it should be all right.
Professor Rosenfeld, I enjoy your work on coenzyme 10, and I know that you are a great transplant surgeon also. By your opinion, do you think coenzyme 10 can extend the transplantation time, or can it an alternative to heart transplantation?
An alternative?
Yeah.
Well, I think certainly we've had some patients who seem to benefit a lot from it. I'd only be talking about anecdotal evidence, but I used to go to the transplant meeting every Friday morning at the Alfred, and they'd have some of these patients that were really sick and they weren't going to get a transplant, and they said, oh, you can give them coenzyme Q10 if you like, and some of them did benefit from it that would have had a transplant otherwise. So I think there probably are some patients that would avoid having a transplant. I can't really say how many, but certainly I think that would be the case, where we can't really answer that question. But in certain individuals, it's certainly got a big benefit. Interesting thing about coenzyme Q10, some people seem to respond to it better than others, and some have a really good response and some don't. So I think if someone responds well, maybe they could avoid a transplant.
Okay, so we can proceed to another point.
All right. So a few years ago we did a study on meta-analysis of clinical trials of coenzyme Q10 and hypertension, which we published in the Journal of Human Hypertension. Medications used to manage hypertension are effective. However, many have undesirable side effects, renal, cardiac dysfunction, and some of those were mentioned at this morning's session about the side effects of heart failure treatments and also antihypertensives. CoQ10 can protect. So how can CoQ10 lower blood pressure? Well, probably as an antioxidant, it can protect nitric oxide from destruction by oxidation. In our bodies, the circulation is maintained by nitric oxide. We're all secreting nitric oxide into the blood vessels, and if there's a lot of oxidative stress, this can be destroyed, and hence the dilator effect is lost, and there can be constriction, and hence blood pressure can be higher. So by giving an antioxidant like coenzyme Q10, it could improve things. So cardiovascular disease lowers CoQ10 levels, and there have been many studies describe the capacity of coenzyme Q10 to control hypertension. So we did a review all the published trials of coenzyme Q10 for hypertension and assess the overall efficacy and consistency of therapeutic action and look at the incidence of side effects. So this was a very strict evidence-based review, 12 studies at a total of 362 patients in which CoQ10 had been used in therapy of hypertension, 3 randomised control trials, 1 crossover and 8 open label, and due to differences in methodology and presentation, we analysed these 3 different groups separately. Now let's look at the open label studies. These were just ones where the coenzyme Q10 was given to a patient. They measured the blood pressure before and afterwards. So we can see here, this is a forest plot, and on this side of the line, that's the reduction in blood pressure. So went down here, that's a reduction in blood pressure. We can see all the trials here, and that's the mean reduction, which was 13 millimetres of mercury systolic blood pressure lowered, and the same for diastolic blood pressure, around 10 millimetres of mercury lower after having coenzyme Q10. But you'll note that some of these trials were done quite a while ago, 1981, 1976, so they certainly didn't necessarily have all the modern treatments for hypertension. What about the randomised trials? There were 3 that fulfilled the acceptance criteria, and again we can see a significant drop in systolic blood pressure of 16.6, nearly 17 millimetres of mercury. The treatment group, the diastolic blood pressure, went down by 8, whereas the placebo group did not fall significantly in either group. And there was one crossover trial which had a similar result. So we concluded CoQ10 has a potential in hypertensive patients to lower systolic blood pressure by up to 17 millimetres of mercury, diastolic, and up to 10 millimetres, effective in its own or in combination with conventional antihypertensive medication. The incidence side effects is low, and other published studies of coenzyme Q10. But it was just mentioned, this was done, a lot of these trials were done a long time ago. So we really need, should be validated by a contemporary perspective randomised trial of coenzyme Q10 in hypertension. It's a little bit like coenzyme Q10 for heart failure, which was before the QSIM-BIO trials. A lot of trials, some of which were a bit outdated. With hypertension, it's very suggestive, and it would be good to do another trial. But certainly, there's nothing wrong with that, with using coenzyme Q10 to see if it can improve therapy of hypertension, and may be able to reduce some of the antihypertensive drugs. So clinical CoQ10 may be utilised either on its own or in combination with conventional antihypertensives. It may have a particular therapeutic role in hypertensive patients with increased levels of oxidative stress, such as diabetes and renal failure. So, another interesting thing we've done some research on is coenzyme Q10 more effective in the elderly? And you've noticed in the QSIM-BIO study in the patients over 65, it was more effective than those younger than 65. So this can, coenzyme Q10 affect the older heart better than the younger heart. So a few years ago, we did a study in rats to investigate the age-dependent response of the heart to coenzyme Q10. We had young rats, 5 months old, and senescent rats, 3 years old. That's like a 70-year-old rat, like a 70-year-old human, treated intraperitoneal coenzyme Q10 for 6 weeks. And then we took the heart out and subjected it to a pacing stress. So it was like running around the block, paced at 510 beats a minute for 2 hours, but there was not an ischemic stress. It just increased oxygen consumption. And recovery of pump function efficiency was expressed as a % of pre-pacing levels. So here are the results, and I'll take you through it in detail, or just in the main results. This is work. How much work did the heart do after the stress? The percentage recovery of the pre-pacing stress. So let's look at the vehicle-treated animals. We can see that after the severe pacing stress, the heart only recovered 20% of what it was before the pacing stress in the old animals, whereas the young animals recovered about 50%. So the old animals couldn't take the stress. Whereas in the coenzyme Q10 treated group, the senescent animals' hearts recovered just as well as the young hearts. So it is sort of significantly better than the untreated ones. And the same pattern for oxygen consumption and efficiency. Then we did a study in humans to study the same question. in human myocardium. And again, being cardiac surgeons, we had access to human tissue. So when we cannulated the right atrium, we took out a piece of the right atrium and put in an organ bath, stimulated it and made it contract. So then we took away the oxygen and the fluid and simulated ischemia. So it was just no fluid, no nutrients, no oxygen, and then looked at the recovery. And this is what we found. So this is the effect of coenzyme Q10 and vitamin E on post-ischemic recovery. So this was where we actually gave the patients coenzyme Q10 and then took out some of their right atrial appendage. So just look at the patients over 70. These were muscle strips. I'm sorry. They were actually, the muscle strips were treated with the coenzyme Q10, not the patients. So you can see here that where we treated the patient, the muscle strips with vehicle recovered about 60%. Vitamin E, a slight improvement, but when they're incubated with coenzyme Q10, there was a better recovery. However, in the younger muscle strips, we didn't see that big effect. There was a slight improvement, but not significant. So the coenzyme Q10 in these aging muscle strips had a better effect than in the younger ones. So concluded coenzyme Q10 has a senescence-specific protective effect against both aerobic and ischemic stress. Now, then moving on to coenzyme Q10 in cardiac surgery. Were there any questions about that, what I've just said? Okay, we'll keep moving. We did a clinical trial of coenzyme Q10 in cardiac surgery, which we published in 2005. It was a randomised double-blind placebo-controlled trial in elective cardiac surgical patients, and we gave them coenzyme Q10 or placebo for 2 days prior to surgery to preserve and enhance their response to surgery. These were the two groups, and these are demographics. We can see they were basically elderly patients, mostly having coronary bypass surgery, and there was no difference in the other parameters. Now we're able to again obtain mitochondria from the right atrial appendage, and this shows the coenzyme Q10 level, which I showed you before, showing that the coenzyme Q10 was entered the heart and entered the mitochondria. And also, therefore, more efficiency of oxygen consumption, which I showed you before. And then this time we took out pieces of the muscle from the patient. So this wasn't an organ bath experiment. The patients had actually been having coenzyme Q10 capsules for 2 weeks. And then we took out a bit of their heart and we tested them in the organ bath. So again, we subjected them to simulated ischemia. And we found the recovery of developed force in the muscle strips. So the placebo after the simulated ischemia recovered 50%, whereas the CoQ10 patients recovered nearly 70%. So the muscle taken from the human hearts of those patients that had been taking coenzyme Q10 had a better response to ischemia, simulated ischemia. And we also measured the stroke work in the patients. This is like a Starling curve. This is stroke work index against wedge pressure. And normally you should get an upsloping curve as you increase the filling pressure. We tilted the patients down in the bed so they got increased filling. And the coenzyme Q10 showed an increase in cardiac index, whereas the placebo group had a flattened curve with a poor response to filling. So from that we include preoperative CoQ10 in elderly patients, increase the content of cardiac muscle, improve cardiac mitochondrial efficiency, increases myocardial tolerance to hypoxic stress, and improved cardiac pump function. Now, just the last little postscript to this talk, coenzyme Q10 in physical exercise. I've been working with a German sports medicine to do a review of all the studies that have been done of coenzyme Q10 in sport, because quite a few athletes take coenzyme Q10, and does it do any good? Well, we reviewed 28 studies over a 25-year period, and I won't go into the detail, but basically we concluded that coenzyme Q10 can have a beneficial effect on physical performance provided given appropriate form, adequate dosage, time of administration, and when performance is assessed by a reliable and reproducible measure of output. So if you take coenzyme Q10, enough of it in the right form, you can improve physical performance. So, conclusion. I think it can have a beneficial effect in a variety of situations: heart failure, hypertension, aging, cardiac surgery. So therefore I think it holds great promise for clinical use. Thank you.
We have already learned from you that it can reduce the blood pressure to somewhat significant level, right? You have this data about the blood pressure in the Q-Symbio, because usually if something can reduce the blood pressure that much, maybe it can be quite dangerous for the patient with undecompensated heart failure. For the Q-Symbio, do any change in the blood pressure happen in the Q10 arms?
Yeah. I don't believe so. That would have been recorded as a side effect, hypotension. And I think it's interesting that coenzyme Q10, if you and I take coenzyme Q10, it won't lower our blood pressure. It only seems to work where there's an increased oxidative stress. So in hypertension, it does lower the blood pressure. But in the heart failure patients, I suppose it had two effects. It may have had a vasodilator effect, but also increased cardiac output. So presumably they cancelled out. But certainly they didn't get hypotensive. That didn't occur.
You don't see any change in the blood pressure in the active treatment in
No, there wasn't. There wasn't.
So actually it works at the blood vessel too, right? For the coenzyme Q10. Does it work at the vessel level too, beside the heart?
Yes, well, I mean, you might think that if you give someone with hypertension something that stimulates their heart and make their blood pressure higher, but it probably has a more important effect in dilating up the circulation by protecting nitric oxide, so that it doesn't seem to have that problem. It does lower the blood.
It seems to reduce the oxidative stress as a blood vessel too, right?
Yeah, I think it then dilates the blood vessels, and I suppose that would allow more efficient cardiac function, possibly.
I think that being a cardiac surgeon, you can have a good access to the myocardial tissue of your patients, and that gives many research opportunity in doing that. I think that we cardiologists here would do the same in the future, to contact with your CVT colleagues and contact with your lab and see many new things about that. We can do some more research with them to get new information in the future. Any other questions about the coenzyme Q10? Please.
As we talk about CoQ10, I actually have been using a lot of CoQ10 in my patient without good evidence.
Is it for the cosmetic reason?
No. No, but when patients ask me they want to take something like vitamin, I wouldn't recommend vitamin C, vitamin E or anything. I would say CoQ10 until Symbio study come out. But one of the most I wouldn't say indication, but reason for using CoQ10 is myopathy induced by statin. What is your thought on that? Is it? I mean, I use it sometimes if I don't have any other options to do. I mean, other option would be changing to other statin or reducing the dose or not taking statin. Sometimes some patients that can't afford, I would ask them like, would you mind try using statin? And I didn't see any slide on that. Would you mind giving your thought on CoQ10?
Well, I think we all know that statins have a lot of side effects, and they can be myopathy, cerebral effects, impaired cognition, and also a tendency to heart failure. Then you can say, what is the mechanism of this? Well, certainly there's very good evidence that statins lower the blood level of coenzyme Q10. And some people say, well, it's just in the blood, not in the tissues. But there are quite a few studies now that show that it does lower the coenzyme Q10 level in skeletal muscle. Now, if that's the case, then every patient that gets muscle cramps with statins should take coenzyme Q10 and the cramps will go away. But that's not the case. It's more complicated than that. I think, well, you can comment on this perhaps. Did any of the patients that you gave the coenzyme Q10 lose their muscle cramps? There's been some work done on this that showed that certain alleles of certain genes seem to dictate the response to CoQ10 in muscle problems. So probably that's only part of the story, and not everybody that has muscle cramps keeps the statins going and takes coenzyme Q10 and the muscle cramps go away. But I get the impression that quite a few people that does happen. Did you have any impression of that? Does it help or not?
Just some random cases. Some patient who try taking it, some of them would say it helped, some wouldn't. I usually ask them to take for like 2 weeks and see how the symptoms go, but definitely I'm looking forward to see other evidence on that. I would thought that statin induced myopathy would be easier to study since the muscle biopsy is easier than the heart biopsy.
Yeah.
But unfortunately, we don't have that many study of the coenzyme Q10 because of, prior to this substance or compound, not many industrial sponsors trying. I hope that one day the government agency like the NIH would do a try with all these micronutrient compound.
I think that what you said to us has given us a lot of ideas and opportunity about what we should do to our difficult to treat patient and also for the research in many aspects of cardiovascular fields. So any other question? Actually, I do a small research with coenzyme Q10 many years ago. In that time, it was introduced into our country by a certain pharmaceutical company from Japan, coenzyme Q10, and I give it a big dose to the valvular heart disease, heart failure class 2 and 3. But the number of the study was not very much. However, I compare it to the placebo, and it doesn't seem to work at all, but the number is it can has an effect in this group of the patient. I published this paper in the local journal, so
Right.
it is not it
No
appear
effect.
no effect at all.
Yeah. Well, I think that's been the case, that there have been a lot of these little studies done. We don't know what preparation was used and whether they had an adequate dose or whatever. So I think that was, and quite honestly, Carl Folkers, who was one of the pioneers with coenzyme Q10, he had a number of little studies like that were not very convincing, and that gave it a little bit of a bad reputation. And I think there needed to be some rigorous studies, and it's taken years before they happened. So I think now there's one, there's quite a few. We did one in Sydney a few years ago in the transplant unit and gave patients coenzyme Q10. It improved their NYHA status, only 26 patients. That was a little study like yours, and it did improve them. But those sort of studies are hard to hang your hat on and be absolutely certain. So that was why we needed at least one big study, which we've got now.
And one thing that we must concern about is the publication bias, because of the old data from the coenzyme Q10 comes from very small study, and the publication bias is if the trial turns out to be negative, sometimes it was not published in the literature.
Yeah.
So when we do the meta-analysis in any kind in the past, usually we see the positive result, but we don't have any idea about the trial that is failed and is not registered by the government, and they don't register it, so we don't have anything bad about all this new information. So that's one of my concern because the data from coenzyme Q10 appears in the past many years ago too. And we do the meta-analysis, then maybe a bias in doing things like this.
Yeah, that's right. So publication bias, very important.
All right, I think that we spent our time quite well, effectively, and I think it can give you all the idea of using this new treatment in the difficult case of our cardiovascular patient. And also, I think that we can encourage our research fellow to do more research in this new kind of treatment in many fields of cardiovascular medicine. Thank you very much.
Thank you.